guys, welcome back to another video. If you are new here, my name is Alexis. So I've had a few people ask me to make more videos about the NICU, and after my very lengthy video titled So You Want to Be a NICU Nurse, I wasn't really sure what else I could talk about because I covered so much, but I've been doing some thinking and I've finally come up with some new ideas. So today I'll be talking about what it's like to admit a new patient into the NICU and what my role is as a NICU nurse. So I do have a good bit to cover, so let's go ahead and get started so that this video isn't too long. Alright, the first thing that I want to mention is that we can get patients from several different places. We may admit a new patient that was literally just born in L&D about 15 minutes ago. We can admit a patient from a different hospital. We can admit a patient from a different unit in our hospital. Like, let's say we have a baby that was born yesterday. They're healthy, they were in the newborn nursery, but then they start having problems breathing. We can admit them into the NICU. Or there can even be something like, let's say a pregnant woman gets into a car accident, so she's rushed to the ER, and then she has the baby there. That baby can come up to the NICU. So you never really know where the baby is going to come from. Another thing that I wanted to mention is that babies under a certain weight or gestational age will automatically come into the NICU. So we have what's called ELBWs, which stands for extremely low birth weight babies. These are your really tiny babies that were born at about 23 or 24 weeks gestational age, and they're like under 1,000 grams and can fit into the palm of your hand. Let's say on the other hand, we may admit a baby that is a whopping 12 pounds, post-term baby. So there's a wide variety of what we may see in the NICU. When I come into work, I don't know what my assignment is going to be, so that's the first thing that I check. So if I go look at the assignment and I see that there's an NA1 next to my name, that means that I will be admitting a new patient. NA1 stands for New Admission 1, and it means that you will be admitting the first new patient that comes into the unit during your shift. If there's an NA2 next to your name, then you will be admitting the second new patient that comes into the unit during your shift. And of course, if there's an NA3 next to your name, then you will be admitting the third new patient that comes into the unit. If you're up for a new admission, it's very important that you are prepared, especially if you're NA1, because you don't know when you're going to get your new patient. You can have a new patient come in right at 7:15 at the very beginning of your shift, before you're even done getting a report on your current patients, or you may have a patient not come until about 6:30 p.m. at the very end of your shift when you're about to go home, or a patient can come sometime in between them. There are even times when you're up for NA1 and you don't get a new patient at all because no one gives birth or the babies are perfectly healthy and can stay upstairs with their mom. So let's say that I'm up for NA1. So the first thing that I want to do is go ahead and get a report on my current patients and do their care times if I can. And as soon as I'm done with that, then I will look and see which patients are back in labor and delivery. And we can actually see how far along those moms are. So are they 2 centimeters dilated, so I have more time? Or are they 8 centimeters dilated, which means that they're going to be giving birth pretty soon. So I can check and see for that. And also throughout the day, the charge nurse will let you know what's going on and keep you updated so that you're just not left out in the dark. So let's say that I've gotten a report, I've gotten my care times out the way. The next thing that I want to do is check the bed spot where my new patient is going to be admitted. I want to make sure that it's clean and that I have all of my supplies. So if I notice that I'm missing some supplies, then I will go to the supply room and gather whatever else I need. It's very important that you stay prepared because you don't want to have that new patient come in and you're not prepared and you don't have everything that you need. That's not good. So whenever there's a delivery, our phones will go off. It'll have like this little special ringtone, and sometimes they'll even make an announcement over the speakers. So that way you know that there is a delivery and that there's a good chance that a patient will be coming into the NICU. So as a NICU nurse, you are allowed to stork, and that means that you can go back to L&D with the charge nurse and doctors and actually help out with the delivery. And this is optional, so you can either do that or you can stay in the unit with your current patients and wait for someone else to bring the baby to you. Alright, so let's talk about what happens when your new patient arrives to the unit. This is when my adrenaline starts pumping and I get really nervous and I start to freak out. So I think the best way to explain this is to talk about the episode of The Office when there's the fire drill. So just think about Michael Scott saying, OMG, it's happening, stay calm, but he's really actually freaking out.
Do an air duct. Oh my God, okay, it's happening. Everybody stay calm. What's the procedure, everyone? What's the procedure? Stay calm. Wait. Everybody Calm down!
That is how I am on the inside. I am super nervous, but on the outside, I am cool, calm, and collected, and I do everything that I'm supposed to do as the NICU nurse. And so when they bring the baby in, they're not just going to be like, okay, here's your patient, bye, and leave you by yourself. They're going to help you out. It's going to be a lot of doctors, and all the other nurses in your pod will be a lot of help too. So you're not just on your own. You get a bunch of help. So the first thing that you want to do when the baby comes in is hook up the baby to the monitor. You want to put in the MRN so that they're ready to go. Another thing that we do when the baby first comes in is to check an initial temperature and blood pressure. So we do one right when they come in, and then we do one every 15 minutes for the first hour, and then every 30 minutes for the second hour. So let's say, for an example, we get a patient that is preterm, gestational age of 36 weeks and 2 days. So they're pretty close to being term, but not quite there. So let's say the baby comes in at 1 p.m. So we want to check that initial blood pressure and temperature at 1 o'clock. And then we get another one at 1:15, 1:30, 1:45, 2 o'clock. And then we're going to do one for 30 minutes for that second hour. So at 2:30 and 3 o'clock. Another one of the first things that you want to do is check the baby's blood glucose. You want to make sure that the baby is not hypoglycemic, because if they are, then you're going to have to put in an IV and start some fluids. Another thing that you want to do is check the baby's abdominal girth, head circumference, length, and weight. And it's very important that you put those measurements in as soon as you can so that the provider can put in orders and determine the correct dose of medication that the baby may need. So once the baby is settled in, the doctors will start to leave, and then it'll be a little more calm, so you can do your full head-to-toe assessment as the nurse. So you want to check the baby's anterior and posterior fontanelles, you want to check their sutures, you want to get a close look at the baby's face, see if it's symmetric, asymmetric. You want to see, are the ears low set, is the nose bridge widened, so just check to see what the baby looks like overall. You want to check to see if their palate is intact. You also want to listen to their heart sounds, lung sounds, bowel sounds, and check capillary refill, see if the baby has had their first meconium yet, if the baby is peeing yet, is there pain anus, do you see a sacral dimple with a tuft of hair. So you want to do a full, thorough head-to-toe assessment so that you get a good picture of the baby. Another responsibility that you have as the NICU nurse is to do eyes and thighs. So eyes is basically just inserting some gel into the baby's eyes called erythromycin. So this helps protect the baby from any type of infection that they could have had during the birthing process. And then thighs is administering a vitamin K shot right into the baby's thigh, because when babies are born they have very little vitamin K. So this is necessary to help them form clots in their blood so that they're not just, of course, bleeding out. It's very important that they get this. So then once you do that, the baby starts to get a little more settled in. Then let's say the baby's dad or another family member comes in to see the baby. Of course, mom can't come in just yet because she literally just had the baby and she has to be cleared by the doctors before she can come down and visit her baby. So as a nurse, it's your job to explain what just happened to the dad and whatever family members come down. And you just explain the roles of the NICU to the parents and answer any questions that they may have. So that in a nutshell is basically what happens when you get a new patient into the NICU. And let's say that is for a patient that is not extremely sick. So that was just a general overview of the things that we usually do. However, there are times when we have patients who are a little more sick, so they require more things. So there are times when a patient is having trouble breathing, so we might have respiratory therapists there to start bubble CPAP, or you may have to do a rapid sequence intubation. There are other times where we might have to do a blood culture, or the providers decide to start a UAC and a UVC. So those are lines that go in the belly button. The UAC is the umbilical arterial catheter, which goes in the artery, and the UVC is the umbilical venous catheter, which goes in the vein. So when a provider decides to start a UVC or UAC, everyone in the room has to put on a mask and a hat because it is a sterile procedure, and as a nurse, you're just there to help out the provider and maybe grab extra supplies if they need it. Also, if we admit an ELBW, they have special needs too, so we have to get out a special isolate for them and heat it up, and they have to be started on special fluids. So you really don't know what you're going to get until you get your patient, and I cannot stress this enough. Being in the NICU, especially when it comes to admissions, is one of those things where you just have to do the things that are expected, but also you have to go with the flow because you don't know how sick your patient is going to be or what their needs are going to be. On the one hand, you can have a very simple admission, or on the other hand, you can have a very chaotic admission with a patient who is very sick. There's one time when I had an admission and I was on my feet for 5 whole hours. I did not get to sit down once because my patient ended up being a lot sicker than we expected. So it's just one of those things, you never know what to expect. Overall, admissions can be a little scary for me because I am still a new nurse. I've only had 2 on orientation and 2 since I've been off orientation, so I'm still learning, but for the most part they usually go pretty well, and I always have so much help. So that was just my general overview of admissions. If you guys have any questions, feel free to ask. I hope you found this video helpful, and I will catch you in the next one. I hope you have a lovely day.